So TOS essentially is a whole constellation of symptoms that result from compression of neurovascular structures within the anatomic region known as the thoracic outlet. It's an anatomically complex area, as you all know. It really has several different levels where compression can occur. It can either be within the interscalene triangle, at the costoclavicular space, or in the space behind the pectoralis minor, the subcoracoid space, or at multiple intermediate spots anywhere along the way. Not to induce flashbacks from medical school, but the important thing to remember, a few anatomic points. The normal brachial plexus anatomy exists in less than 50% of the population. And in a fair number of patients, there exists either what's called a prefixed brachial plexus, in which case the C4 spinal nerve, which is not shown here, merges and helps to form the upper trunk with an almost absence contribution of T1. That occurs in anywhere from 15 to 65% of the population. And there's also a post-fixed brachial plexus that occurs anywhere from 5 to 60% in different autopsy series, in which case there's a very small contribution from C5 and a larger contribution from T2. I think that may explain why a number of these patients have all sorts of varied symptoms, and that there's so many different anatomic variations within the plexus. You can get compression in the same or in two different people, which will present with completely different constellation of symptoms. Another important anatomic thing to recall is that embryologically the scalene muscle begins as a solid muscle mass, and as the forelimb develops, the brachial plexus and the vascular structures split the scalene into different components, the anterior and the middle scalene. And in a very high percentage of patients, at least that I see surgically, there are slips between these two muscles such that the brachial plexus doesn't completely split the muscle. One trunk will go through the anterior scalene or in front of the anterior scalene, and others will go between the anterior and the middle scalene. And this is just a photo from a recent patient. You can actually see here's the part of the anterior scalene muscle here, sort of a front edge of it. Here's the back edge, and this is the upper trunk splitting it right in two. Here's the middle trunk going behind the anterior scalene and the middle scalene back here. So these interscalene bridges, or these muscular slips between the trunks of the brachial plexus, may also contribute to a lot of different symptoms that patients can get. And finally, it's important to recall that there are multiple suspensory ligaments of the pleura, which have also been termed Roux bands, that Dr. Roux described. These go from either the vertebral column or the first rib itself onto Simpson's fascia. The most important one is probably posteriorly here, this costoseptocostal ligament, which can trap the T1 nerve root right here, as it has to enter out of the thoracic cavity and go up over the top of the first rib. So all of these things are important anatomic issues to recall as you're working these patients up, and certainly at surgery. This is just an example of those suspensory ligaments. Here's a patient through a supraclavicular approach where the anterior scalene muscle has been divided, and you can see these suspensory ligaments inserting on the pleura. It's very difficult to see those posterior ones, which is why I showed a cartoon, but we certainly do see them surgically. So the symptoms that patients develop really depend on which structure is compressed. The far more common symptom complex relates to compression of nerves, or neurogenic TOS. That occurs in a very rare form, which is called true TOS. That has a discrete anatomic abnormality, the Gilliatt-Sumner hand, in which case the ulnar-mediated hand muscles become atrophic. This is an example of a patient with abductor pollicis brevis atrophy. You can see from the side view there's a sort of wasting of the thenar eminence. They also get wasting of the first dorsal interosseous at the first web space, and also the adductor digiti minimi. Again, very uncommon. I've seen 3 patients in the last 12 years, but these are the ones where it's a fairly straightforward diagnosis. The far more common, about 95%, certainly in my own practice and in most of what people report, is the so-called disputed or nonspecific neurogenic thoracic outlet syndrome. And I think that's really the thrust of most of what I'm going to talk about for the rest of the talk. That's really where the controversy lies. And finally, there's vascular thoracic outlet syndrome. It can either be the Paget-Schroeder syndrome or venous obstruction of either the axillary or the subclavian vein as it crosses the costoclavicular space. These people present with characteristic swelling, skin discoloration, and a generalized ache of their arm. Again, it's a diagnosis you can almost make over the telephone. And finally, a much more rare form, arterial TOS. This is just almost always associated with a cervical rib. This is a patient of mine who had had a previous cervical rib resection, although as you can see it was just a tiny bit about 20 years ago. that did not really did not prevent compression of the subclavian artery with subsequent post-stenotic dilation and eventual aneurysm formation. This is just an operative slide from that same patient. You can see the subclavian artery aneurysm, which was resected and reconstructed with Cortex. Again, this accounts for about 5% of all TOS series, with the vast majority being the venous form. This is about 95% of patients, and again, almost all in this nonspecific or disputed category. So since vascular and the true neurogenic forms usually have clear objective findings, the diagnosis is rarely in question, and in reality, the treatment's rarely in question. In most of those patients, they're going to need surgery. Because they're typically young, I would not recommend stenting of either the vein or the artery. The long-term durability issues of stents are fairly poor, especially in this area where there's a lot of movement. They tend to fracture and eventually thrombose. So I think the vast majority of these vascular patients, and certainly the true neurogenic TOS, all require surgery. The real dilemma is in the largest group, that disputed neurogenic TOS. They typically present with symptoms of pain. I'd say of the last couple hundred patients I've seen, one patient did not complain of pain. They purely had paresthesias. Where they almost all complain of pain is in the lateral neck and upper trapezius region. They'll also have pain down the arm. About half of the patients will have sort of a diffuse, non-localized pain of the upper extremity. The other half will tend to localize. About 1/4 of those patients that do localize will localize along the lateral arm or the upper trunk distribution. That's the lateral arm down to the thumb and index finger. And about 3/4 of the patients that localize will be along a lower trunk distribution, the medial arm and the 4th and 5th digits of the hand. A lot of them will present with medial scapular pain that's fairly characteristic, and also anterior chest pain in the pectoral region. Also, a high percentage of them will complain of occipital headaches. The real dilemma is there are a lot of other syndromes that can produce these same symptoms, and so trying to sort out which is truly from neurovascular compression and which is just some other type of syndrome mimicking these symptoms is the real challenge. Another form of disputed neurogenic TOS is the so-called pectoralis minor syndrome. Remember, one of the levels within the thoracic outlet, that subcoracoid space, or the space behind the pectoralis minor, is another relative area of potential compression. It may happen more frequently in overhead athletes, particularly, it's just envisioned on a diagram, but you can get instability of the humeral head, which can roll forward and essentially create sort of a lever arm on the neurovascular structures here in that subcoracoid space. That Pec minor syndrome, again, has a relatively characteristic presentation in terms of pain, mostly in the chest, axilla, and upper trapezius. It's much less common to see patients with pain in the lateral neck and down the arm, although it can exist, and also it's rare that they'll get paresthesias, and if they do, they typically tend to be non-localizing. Again, as I mentioned, the real challenge is trying to figure out what else they might have. And I think the more you know about the other conditions that can mimic TOS, the better job you're going to do trying to sort these problems out. And I really try to break it down into different sort of pain generators, if you will, whether it's a bone or joint problem, whether it's a muscular or soft tissue problem, or whether it's a direct sort of neurally mediated pain from a nerve injury. Spine pathology is probably the most common. Anyone over the age of 40, you have at least a 30% chance of having an abnormal MRI, even if you're completely asymptomatic. So again, the incidence of spine pathology in the general population is extremely high, and there are multiple levels within the cervical spine where compression can occur. Certainly, disc problems are the easiest to work out because they tend to have a clear picture on MRI study. But you can also get annular tears, which can create inflammation, which is less clear on imaging studies. So you can get a problem in the disc. You can get either a central canal stenosis or a foraminal stenosis in this region here, irritating the spinal nerves. You can also get facet joint issues. If this inflammation of these facet joints is severe enough, it can actually mimic a radiculopathy by causing inflammation and swelling in here, which again is less visualized on MRI studies. And also these dorsal nerves here, the dorsal root nerves, innervate these facet joints at 2 different levels. So you tend to get a very non-specific, non-localized pain, which can mimic symptoms of thoracic outlet syndrome. Shoulder pathology is another thing that's very important to try to rule out. Rotator cuff instability and multidirectional glenohumeral instability is a very important thing to try to sort out on physical exam. If you've got instability within the shoulder joint, that can create motion on the neurovascular structures and again mimic symptoms of TOS. They'll get identical symptoms, but the problem isn't from compression within the thoracic outlet. Also, there's a couple of nerve entrapment syndromes of either the suprascapular nerve at the suprascapular notch or the axillary nerve, which again can cause symptoms of shoulder, upper scapular, and arm pain. Finally, myofascial pain syndromes are very poorly understood. It's thought to be related to hyperirritable skeletal muscle, either at the neuromuscular junction or within the muscle itself. And what we think happens is that the nociceptors, or pain receptors, deep within the muscle are inappropriately activated, and that produces a very sort of deep aching pain that's poorly localized. If you were to inject muscles with saline in normal volunteers, you can actually mimic, especially if you inject the scalene muscles or the trapezius muscles with saline, you can mimic symptoms of TOS. So again, activating these nociceptors locally can produce radiating symptoms that are very difficult to distinguish from true thoracic outlet syndrome. Finally, as thoracic surgeons, we should never forget to look for superior sulcus tumor, particularly in smokers or older patients, which can produce lower trunk symptoms, obviously. Brachial plexus neuritis, which is a self-limiting phenomenon, or Parsonage-Turner syndrome, and a variety of other syndromes. I just listed this one here because, again, it can almost completely mimic symptoms of thoracic outlet syndrome. Besides pain, the vast majority of patients, at least 95% of the people that I see, also have altered sensation, either paresthesias or numbness, and it's important to have patients distinguish between the two. Typically, they will be localized to the hand, either in a lower trunk distribution, the 4th and 5th digits, or in an upper trunk distribution, the thumb and index finger. But the problem is there is a lot of different conditions, much like pain, that can also mimic paresthesias of the hand. The most common causes of paresthesias of the hand are carpal tunnel syndrome. And in fact, people who say, when I wake up in the morning, my hands are numb, 95% of the time that's going to be related to carpal tunnel syndrome. Another common thing is I have to shake my hands out, and then they kind of wake up. Again, very, very characteristic of carpal tunnel syndrome. Cubital tunnel syndrome, or ulnar neuropathy at the elbow, also has a fairly characteristic presentation in that the sensation tends to split the ring finger, unlike in TOS, where it's the entire ring and small finger. And finally, cervical radiculopathy. So these are far more common causes than TOS of paresthesias of the hand. Less common causes, including early stage peripheral neuropathy or different entrapment neuropathies of the forearm, either radial sensory neuropathy, the ulnar nerve at Guyon's canal, the wrist, and a median nerve entrapment in the forearm also can mimic paresthesias of the hand. And finally, less common causes, TIAs or stroke or a syrinx. Motor symptoms tend to be very vague, and on physical findings, motor findings are fairly rare, but patients will commonly present or complain of just generalized weakness or early fatigue, and also a lack of coordination. They have fine motor movements. Selecting the right key on a keychain typically will be difficult in a lot of these patients, even though on exam they'll have completely normal strength. Other signs of nerve damage, including tremor, fasciculations, or myokymia, which is just a much finer type of fasciculation, or muscle atrophy, are also very important findings to try to elicit. Finally, there are a whole host of what were thought of as autonomic symptoms that can be associated with thoracic outlet syndrome, and that led to a fairly high incidence of performing sympathectomy. I think it's becoming more clear that it's really not truly the autonomic nervous system, but it's actually a small fiber pathology. A delta fibers, C fibers, and sympathetic fibers all fall into this large small fiber category, so it's not purely the autonomic nervous system that's mediating a lot of these findings, but we see things like neurogenic edema, either vasomotor or pseudomotor instability, people presenting with blotching, with hyperhidrosis, and also trophic changes of either the skin or the fingernails all seem to be mediated by pathology within these small fibers. So in terms of the evaluation, what I try to do is obviously get a fairly detailed history. About half of the people present with some history of an injury, and that seems to be split evenly between motor vehicle accidents and repetitive strain injury. The details of the location of the symptoms are also critical. Again, I think the more you know about the symptoms that mimic TOS, the better job you're going to do. And finally, I think what's important is getting an overall idea of the general sensitivity of their nervous system. There's an emerging concept of central sensitization, where the secondary and tertiary neurons within the spinal cord and brain seem to be sensitized such that what would otherwise be a non-noxious stimuli can present with a fairly high degree of pain. So these intermediary neurons seem to be activated. So getting a general sense of what their overall sensitivity to pain is probably important. Finally, a fairly thorough neurological exam. I look for their posture, both their head-on-trunk posture, looking for particularly a very forward head position. I look at the scapula on trunk posture. We always think